I just thought I would spend a little bit of time introducing where this meeting is going to try and get to this year. And it's probably worth just stopping for a moment because of the momentous events of the last week, and many of our American colleagues are in the audience. Just to give you the voice of experience, because we've done this too, and you'll know in your medical training that there are 5 stages of grief. Well, I suspect you've been through denial and you've been through anger. You're probably sort of at depression now. So there's lots of alcohol at the back to deal with that problem. But it is a momentous time, and if any of you want me to speak up with you because you can't get onto the Canadian immigration website, I'm quite happy to speak up for you in high places. So, but it's a relevant discussion because, of course, healthcare has been a feature of many of these discussions. The NHS was the argument for why we should be Brexiting, because the NHS wasn't doing very well, and it was used as an argument why we'd be better out of the European Union. Don't ask me the logic of that, because there's not a lot of logic in these arguments. But healthcare is a crucial piece of this, and in another direction, for whatever reason, on the other side of the Atlantic, Obamacare was clearly a lightning rod for discussion in America, again, in a relatively confused way. And we see already this morning people are backing away from promises made because it's often more difficult to take privileges that people have away than it is to give them in the first place. But this has got to do with the fact that healthcare, medicine and healthcare, is a pretty central bit of the cultural framework of most Westerns and increasingly developing countries. And we talked last year about the important role of innovation in healthcare settings, and we had great discussions about the power of that innovation. But this year, I think we've decided to tune this much more on if all innovations stopped, there's still quite a lot we could do to make systems better. We will continue to have tons of innovation, so for the cell biologists out there, you don't need to worry, we won't take your jobs away. But the truth is there's a ton of stuff that you can do in healthcare systems to make them run better, and that's really evident in single-payer healthcare systems that have huge potential, but haven't really, in my view, recently delivered what they could deliver in terms of delivering the best healthcare for the lowest amount of money in Western societies. And part of the problem, of course, comes from what we talked about last year, which is the drive and success of the innovation agenda that's been going on for 20 or 25 years in healthcare. I was reflecting, to be clear, I'm not that old, but in my lifetime as a doctor, if you look at the successes of biomedical science, you'd think I was ancient because it's terrific. And so in the lifetime, since I was a medical student here in the 70s, there's been a 75% reduction in cardiovascular disease mortality. So when I was a kid, everybody's grandparents died of heart disease, and actually a lot of people's parents died of heart disease. That essentially doesn't happen anymore, and 3 out of 4 people who would have died don't die anymore. But also in some of the other major chronic diseases, we worry about cancer, but the truth is there's been a 50% reduction in age-specific mortality from breast cancer, and that's the result of a multiplicity of different things: better diagnostics, early screening, better therapeutic interventions. But 50% is a pretty big number as well. We're not there yet. And we've had a whole cascade of new therapeutics. Therapeutics for age-related blindness, macular degeneration, I think is a really major issue, because when people get old, they worry really about 2 things. They don't worry about playing football anymore, but they do worry about whether they can see and whether they can think. So we're working on both those projects. Can't really do the thinking thing yet, but we're going to try and get there. But also a whole host of new drugs, the anti-TNF drugs for rheumatoid have been transformational. 20 years ago, in this country, 50% of the joint replacement operations were done for inflammatory arthritis due to rheumatoid. This year it was 0.5%, and that's driven a bit by the fact that there's more non-inflammatory forms, but mostly the fact that we don't do joint destruction because of rheumatoid anymore. It essentially doesn't happen. So the wards are all closed, the doctors don't do what they did, and it's all been changed. We've got a cure for one of the major chronic infections, HCV, and we've got a set of controlling strategies for HIV. Again, when I was a medical student, we hadn't invented HIV yet, but we've been through the epidemic and then through the management and the control, and I think we now need to find a real cure for HIV, but we can manage it pretty effectively. And even increasingly in the developing world, with the availability of a wide number of drugs, I'd be wrong to say it's under control, but it's much better controlled than it was in the 80s and the 90s. We don't do ulcer surgery anymore. We've eliminated what used to proliferate in the UK, which were lunatic asylums. The discovery of the major antipsychotic medications means that many of those psychotic diseases can be treated as outpatients. We've sequenced the genome. And the killer observation is that in my time as a doctor, we've increased male life expectancy by 9 years in the UK. That's a decade. And female life expectancy by 8. And people don't, I often say that, and people don't, they glaze over and say, well, I don't really get it. But, what does that mean? Well, what that means is that you will spend 10 years more with your grandchildren than you would have when I was a student. So now lots of people say, "Oh God, not sure that's such a good idea." But in general terms, it's a pretty good thing. And I guess there's an interesting question about whether we want the next 35 years to look as good as the last 35 years. And I think that's a really important question, because this 35 years those successes have driven some of the most fundamental issues that we're trying to deal with in society today. So how do you manage the pensions business? How do you keep people employed longer? How do you deal with the challenges of chronic disease, which are a very different paradigm than what Fred and I, when we trained, wasn't chronic disease. We were all running around in pajamas, pushing crash carts up and down the halls of hospitals. Medical students don't need to do that anymore, so the world looks really, really different, and it's largely due to that huge surge of innovation that we've seen in the sector in the past 35 or 40 years. So it is a great story, and of course there's lots of opportunity in the next 35 years to double up and do even better. Immuno-oncology clearly is going to work. We will definitely now be able to cure cancer in a way we've never been able to cure before. There's opportunities in cell and gene therapy. We have really exciting fundamental work in aging as a concept rather than an organ-specific problem. Digital health is going to make huge impact on the way we practice medicine. And all these things are going to drive better outcomes, healthier populations. But they will also greatly increase pressure on healthcare systems. And so I think one of the objectives today and tomorrow is to say, well, let's just take it as read that innovation agenda is going to continue, because I can't see anything stopping it. How are you going to deal with the pressures that creates in trying to convert innovation into stuff that's usefully applied systematically across populations? Because in many ways, the huge gaps that we have in delivering outcomes from all that are entirely dependent on the fact that the systems don't work. And the systems don't work in the West, and the systems also don't work in developing countries, because people who need access to appropriate medical interventions often don't get it. And I think there's a really powerful question, which now becomes a policy question, about how we tune and organize our healthcare systems to better decide what they're going to adopt it at scale, diffuse it systematically across the country, and then ensure that you measure the outcomes in a systematic and effective way. And that within healthcare systems, you develop the same innovation culture that's occurred within discovery science up to now. So the reality is healthcare systems are, on the whole, very, very clunky, and they don't look at ways of managing the problem in innovative, creative, and dynamic ways. And I think we need to have better ways to change those systems, because otherwise this huge flood of innovation, that great list of things I've just laid out, many of those things are not delivering the same thing across any jurisdiction because they don't get applied properly. Not everybody in this country gets the same treatment for breast cancer. There's widely variant uses of different interventions, diagnostics, therapeutics. Cardiovascular disease has got better so that there's much more systematic use, but in many of these areas there's wide differentials in the way people use different therapeutic interventions, the way the system works to put patients into the system, and the way the system can afford to pay for some of these new innovations. And those are all, I think, great challenges. So last year at this meeting, I talked confidently about how the NHS was going to try and convert itself from being a very slow, clumsy system to try and change the way it's structured and organized to drive the use of appropriate innovation to greatly improve healthcare outcomes. And as those of you who were here last year will remember, we were right in the middle of a report called the Accelerated Access Report, which has now been published, and NHS England are now apparently using it and applying it systematically. And that the basis of that, as you recall, was to think of healthcare adoption and innovation in a rather different way. At the moment, innovation is very much seen by the innovators, and the innovations get pushed into healthcare systems, and healthcare systems feel that they've got to do it. So they layer innovation on innovation, and they don't ever really extract the value from those innovations because they can't change the pathways that those innovations were intended to fix. And so there are many, many examples of new innovations that have come in that actually haven't delivered cost savings because people haven't changed the way they manage the patients. And it's a really fundamental problem, and I'll give you a really good example. It's an old example, but it's a bit of work done, I think, by a Rhodes scholar in the Department of Public Health. Many years ago, we introduced in the hospital here a PACS system, which is a way for digitally recording x-rays. And it's if I said to you, would you rather have a little lady in a white coat putting x-rays in brown folders and sticking them on a shelf, or a computer, you'll all say, well, get the computer, it's going to be much better. So everybody, both here in North America, bought the computer. They fired all the ladies in the basement. And then this graduate student said, well, actually, that's pretty interesting. Why don't I run the numbers and see whether that was really cost effective? So it turns out that you don't save any money firing those little ladies in the basement because you didn't pay them much anyway. And the cost of maintaining the computer system is about the same as the ladies in the basement. So that was a bit of a surprise to people. But where you save money is the radiologists. So you've got all these high-powered guys looking at x-rays, and when they take x-rays out and look at them, it's actually slow and cumbersome. If you got them all on a screen, you can see x-rays one after the other. Anybody who's sat in a radiology session these days knows how fast it is. And so they compared the Harvard experience with the same PACS system with the Oxford experience. And what happened in Harvard was that they realized that they could do with 30% less radiologists, so they fired 30% of their radiologists. That's how you save money in the healthcare system. In Oxford, all the radiologists just ate more donuts and drank tea all morning. So you can't, this is a really, it's a sort of funny story, but it also reflects what I think is the fundamental problem in healthcare systems, and that is, unless you're willing to measure and quantitate what you're doing when you bring in innovations, and extract the activity that the innovation should prevent you from doing, or should change the way outcomes occur, and quantitate that, then you shouldn't do the innovation thing. So I know this is a hard message for innovators, but innovation only really should be applied when it does those things. So the Accelerated Access Report was really about that, and it was really designed to attack how we get innovation into healthcare systems. And it starts with the idea that innovation would be better if it was a bit more demand-led by healthcare systems. So it's kind of nice. Innovators are out there doing great things, but it's also nice to have a feedback loop so that healthcare systems say, well, actually what we really need is X. and if you invent X, then we will bring it in and adopt it into the system in a much faster and more powerful way. Now, that doesn't mean there won't be things that appear that healthcare systems haven't anticipated that won't be of value, but on the whole, the whole business has been led from the sell side, not from the demand side. And I think there are real problems in that, because all you do is you keep layering this stuff on top, and as has happened in the UK, the thing goes bust, and then you can't do anything. So the concept of the Accelerated Access Review is really broken into three pieces. There's a funnel in, where the healthcare system has to get much better at demanding what it needs, but also identifying way in advance what are the innovations that it really wants to pull into the system. And that means it needs to know what's in development by diagnostics, technology companies, and pharmaceutical companies. And it needs to think well in advance, how would you bring that into a system, and what would the pathways look like if you use that to change those pathways? At the moment, this healthcare system has none of those antennae. It doesn't do horizon scanning. So the most famous story was, we've all known for 5 or more years that there had been a transformative pharmaceutical solution to hepatitis C virus. Everybody knew it was going to be expensive, but everybody also knew it was going to work really well. So the first time, that's a true story, the first time the NHS in England knew that there were new medicines for HCV was when the Gilead rep banged on the door and said, we'd like to sell it to you for X amount of money. And then, of course, there was pandemonium, because they couldn't afford it, B, they hadn't thought about it, C, they hadn't thought about how they might build it into budgets so that they could grow it and so on. So we've then had a 3-year scrap about how we're actually going to do it. So it's a really good example of how, A, you want things to be demand-led, and B, you want horizon scanning, and then, and I think this is probably the most fundamental piece of the AAR, is that healthcare systems can no longer sit aside and just be the targets of innovation. They need to participate in the innovation agenda. They need to say, actually, that's a terrific idea. We would really like to have that. And how do we help you guys prove that it's useful? How do we generate data for ourselves and for you that shows that in real patients it really does what it says it does? And how do we bring it into the system, perhaps gradually, to make sure that we can get it into play? And that addresses what I think is a really fundamental problem from both sides of the story. One is healthcare systems are failing because they can't access innovation, they don't know how to innovate it, they don't know how to innovate, and they can't analyze and assess the data in a timely and effective way. And as a result, they're losing all those opportunities. And on the other hand, industry, to be clear, is also failing, because industry's increasingly throwing stuff at a brick wall where it's not adopted, it's not diffused. And to be honest, a lot of it's too expensive to be adopted in a sensible way, certainly in a single, I mean, you guys in America, you do what you like, but I can tell you, we're definitely not doing that in Europe or anywhere else in the world. And these are cost-constrained healthcare systems. So the ability of industry and healthcare systems to work together to take on some of the difficult and very expensive bits of development, I think is a hugely powerful opportunity. And that too is built into the Accelerated Access Review. So what I'm hoping over the course of the next day or two is that we'll actually have some bold ideas about how do you maybe not invent a ton of new stuff, but how do you make the system work better? Because it's now a systems failure problem that's preventing healthcare and benefits and outcomes to grow at the pace they have over the last 35 years. Anyway, I look very much forward to the conversations over the next day or two, and we should move on with the next talk. Thanks very much.